everybody. Welcome to this week's Infection Control Matters. And we're going to do a little quickie here. I'm in Sydney, which is very nice. And I'm obviously sitting here with Professor Brett Mitchell. Brett, how are you?
Good, Martin. Lovely day outside. We're looking out at the sunshine.
Yes, it's beautiful. Although interesting, I'm coming from the sunshine in the UK and there's leaves all over the ground here and it's better weather than the UK. But anyway, that's your winter and our summer. Anyway, you're very excited today, aren't you? Because your CLEEN study has just started and you've got two major pieces of work going on in this space at the moment. So I thought we'd just have a little chat about that and let people know about it and maybe what to expect coming and how you design the study and that sort of thing. So tell me about the studies.
Okay, thanks, Martin. And you're involved in these too. So
that's true.
So the first one's the CLEEN study. And the idea of the CLEEN study is to address a bit of a gap we thought about with regards to shared medical equipment. And the sort of idea of this study is if we do clean shared medical equipment well and appropriately, does it actually reduce the rates of healthcare-associated infections? And I reckon a lot of people probably struggle with this sort of who's responsible for cleaning shared medical equipment.
Everybody's responsibility, isn't it?
Yeah. No one does it.
No.
And this is where really this came from. And the idea was let's just take a step back and see whether cleaning shared medical equipment makes a difference to infections. And I mean, there's other reasons, of course, why we should be cleaning shared medical equipment, but purely on the sort of infection side of things. So this will be the first randomized control study evaluating whether improvements in cleaning shared medical equipment results in a reduction in healthcare-associated infections. We'll look at the effectiveness and the cost-effectiveness of this study.
Pretty timely, really, because the CDC have come out with a report over the last couple of days in emerging infectious diseases. Well, it's not their report, but they published one from Israel showing a huge increase in the number of Candida auris infections, and they're partly blaming that on shared medical equipment that's not being decontaminated properly because Clade 3 and Clade 1 got into the country where they haven't reported it before, and suddenly it's all over the place. And they're feeling that shared medical equipment has certainly got some part to play in this. And it's pretty timely, really. That's
right. There's that, and there's been some other work, some isolated genomic works in studies in the past would have shown there's been pieces of shared medical equipment implicated in transmission, particularly VRE. I think there's been a couple of papers around that. So there's sort of some reasonable evidence there, but let's do this in an RCT format. So we've got 10 wards and enrolled in this study, and every 6 weeks, 2 wards move from a control to intervention phase. And the intervention is we're actually employing PSAs or cleaners to do 3 hours of dedicated cleaning on the ward. Just focusing on shared medical equipment.
Per day?
Per day. Okay. So this is over and above anything that they do, and they're purely dedicated to doing this.
Right.
So we're working closely with those PSAs with training and all the rest of it. We're looking at the UV dot sort of auditing process to look at the effectiveness of cleaning. So we might be putting in, but are they actually cleaning? And we're using that as a mechanism for feedback for them as well.
So is that measuring the effectiveness of the PSA's cleaning or the cleaning that should go on in between anyway? So, when the PSA turns up for their 3 hours, are they checking to see if it's been done before that, and were the dots put in on afterwards, or how are you doing that?
Yeah, so we've got the control phase where essentially that's current practice, where it should technically be cleaned.
Okay.
And it's interesting, there's variability in those wards. Some are very low. And some are a little bit better. But by and large, we're not seeing shared medical equipment cleaned. And so when we talk about shared medical equipment, we're talking about commodes, drip stands, IV poles, blood glucose machines, computers on wheels, those types of things, PAT slides. So, they're going to focus on cleaning those things dedicated. They've got a little sticker on them and badge, and they don't get disturbed, hopefully, by the clinical staff to do other things. Where they're really interacting well with the clinical staff, so they come and introduce themselves, and they work with the nursing staff, for example, on when can I access that computer to clean it. So that's the sort of the intervention phase.
Any danger that the clinical staff are going to start going, hey, great, these guys can clean my kit all the time for me?
It could do. Yeah. It could do. I guess we want to take one step back and go, does this make a difference? Because the model of delivering the sort of intervention could vary. I mean, you could go with the approach that we've done and go, okay, if this works, is it cost effective to put in 3 hours of cleaning?
That's the difference, isn't it?
Yeah. 3 hours of extra cleaning.
Yeah.
Because there'll be variations on that. You could say, well, why don't we use a decentralized model? If it's effective, is it more cost effective to go, let's move things centrally for cleaning?
Yeah.
So that allows a bit of flexibility.
Need a lot of kit then, though, wouldn't you? But yeah, I mean, it means you can look at all the different approaches.
All different models, yeah.
Yeah.
So we've got about 4,500 participants we're aiming for in this study, or 4,000, I think. And we're about a third of the way through at the moment, and we're on target to achieve that. So we should know early to mid next year about whether this study's...
and the outcome measures are?
Outcome measures are composite outcome of all healthcare-associated infections.
Okay.
So,
and any colonisations as well, or are you just looking at
just infections?
Okay.
So we're using the sort of ECDC point prevalence style approach, but we're doing that frequently. So every ward gets a full PPS every 2 weeks on every patient.
Oh, okay.
So the other beauty with this study, actually, we'll be able to see what the infections are at a ward level to really help inform individual interventions on wards that might have higher rates of UTIs or higher rates of pneumonias or whatever it might be. There'll be quite some decent granular data for the local teams to work with and reprioritise their settings, reprioritise their program if needed.
Okay.
So that's CLEEN. And if you're interested in CLEEN, the website's cleanstudy.com. It's a pretty complicated one.
As usual, we'll put it on the podcast site, so you can just click on the link and check it out.
And you can sign up to updates on there if you want to know more as this sort of evolves. But really excited by this study because it's going to be a world first looking at this sort of shared medical equipment in an RCT format.
Especially in such a range of equipment. So that's really nice. Okay, tell me about iCLEEN then.
All right.
On the start of today.
iCLEEN started today. iCLEEN is, the intervention is the same as the CLEEN study, but this study is actually done in ICU. And it'll be a control phase for 3 months. Where we're just observing what's going on in the ICU by way of the UV audits for shared medical equipment again. And we're also swabbing the environment. So that's swabbing the shared medical equipment as well as sinks. All patients being screened in and out of ICU and weekly. And in the intervention phase, that all continues, except that, of course, the 3 hours of additional dedicated cleaning goes in.
Okay.
And here we're interested in the same outcomes. Does this make a difference to composite healthcare-associated infection rates? And same methodology as CLEEN for that.
But you will pick up colonisations with this because you're screening.
That's right. And in addition to that, we're going to have acquisition data on MRSA-VRE multi-resistant gram-negatives. And where there are infections or acquisitions in ICU patient colonisation or infections, we're keeping those samples. And we're keeping any positive samples from the environment as well. So we'll look at we'll do some genomic work then, looking at transmission potentially through shared medical equipment. So see whether that's actually occurring and how it's occurring, and see whether the intervention makes a difference to negating that. So that started today. Yeah,
I mean, I'm really quite interested and excited by this one because actually you may be able to demonstrate excellent infection prevention and control by showing that there are actually a lot of MDROs in the environment that actually aren't causing infection in patients. And even if they're colonised, it doesn't go on to cause infection in people because their practice is good. So there's an opportunity there to actually use this in a positive way to say, actually, we know these bugs are around, but if you practice well, you can stop people getting infection. Conversely, it may show people are picking up these things from the environment or vice versa, and you'll be able to look at overall levels in the environment as well. Because again, Candidora was highlighted in that study is present on all sorts of surfaces in a viable and a non-viable but viable but non-culturable form for up to 4 weeks. So that was quite interesting as well. So
that's exactly right. I mean, there'll be challenges with this because persistence in the environment might be there. We may not find it too, of course, through some of the smoke. The persistence will be there, and there might be a bit of a lag before anyone becomes colonised or infected, or indeed doesn't.
Well, we don't know how long that is anyway, do we?
That's right. So it does come with some, of course, challenges, but it's going to be a fascinating study with the results on that as well. So really excited about the fact that that's got up and running today. A shout out to the team that's all running this, led by Dr. Kate Brown, who's overseeing this project, and the big team of people that are supporting it, all kinds of different diverse backgrounds. So I'm really excited, and hopefully next year we'll be able to talk about some results.
Yeah, that would be nice. I mean, it is how long before the last group joined this study?
So both of these studies will be done. The data will be finished, collected by November, late November, early December, all going well. And then we'll move on to the analysis stage. So we'll see how complicated and long that's going to take us. But we'll certainly have results next year, possibly middle of the year.
Are you concerned about the fact that you're doing it over the winter? I mean, you're consistent in both, but there are peaks and troughs during different times of the year, and in summer you can get more gram-negative infections or anything like that. Do you think that could affect anything?
Yeah, we gave a lot of thought to the timing of the study, and particularly CLEEN.
I mean, if you want to reduce gram-negatives, you have your control during the summer and the intervention during the winter, and you're almost guaranteed to succeed.
And respiratory infections, bearing in mind, is a composite outcome. What we've done to try and negate that is have the halfway of this study is basically in the middle of the epidemiological peak for respiratory infections. So we're hoping that for that side of things, about halfway through the study is about July time.
Okay.
So we're hoping that it'll be balanced in both control and intervention. We'll have similar numbers in both sort of elements of the seasonality that might affect not just respiratory pathogens, but other things too. So hopefully we can negate that. The other thing we'll do is just look at some sub-analysis of some specific infections. So we'll group things like UTIs, pneumonias, bloodstream infections, surgical site infections together, and individually in sensitive analysis, but together just so we can rule out some of the other upper respiratory tract infections that might be a bit more seasonal, and a few other things that might float about at various times or might be a bit more up and down in their numbers. There might be little outbreaks, for example, of conjunctivitis or other soft tissues, infections that may not be consistent throughout an entire research period. So we'll pull some of those out in sensitivity analysis as well.
Should be really interesting. Hang on a minute, we just had a message from Russo.
That was that ding. He always interrupts us when there's
hang on, let's just give him a call.
I bet he doesn't answer it now.
Ready?
Professor Russo.
Professor Russo, congratulations. Welcome to a special edition of Infection Control Matters. We're recording live, so we thought we'd ring you up and congratulate you.
In all seriousness, Phil, we are live.
We are
live recording. Congratulations on your professorship. Well deserved.
Well, thank you. It's a privilege to be amongst the standings of folk like you.
Hardly.
No, he won't be standing for much longer. We're off to the pub soon.
I know, you bastard.
And what a shame we can't be there to celebrate with you.
I know, that is a shame. Oh, congratulations though, Phil. It's fantastic news.
Yeah, it is. I had my interview last Friday, which but obviously didn't convince them not to give it to me. That's a good thing.
Yeah, that is a good thing.
Did you just get it via email or did you get a phone call?
No, that just came in the mail 5 minutes ago.
Wow.
In email.
And effective from like 2035 in terms of...
Yeah, just the day after I retire.
Oh, that's you'll be Emeritus Professor Phil Russo then.
Well, they are cutting back on costs, so you never know.
That's right, yeah.
I'm highly jealous that you boys are going out to have a drink, so I'd even shout you one.
You could probably afford it now, couldn't you?
Well, we'll have a celebratory...
Yeah, we'll raise a glass to you, Phil.
Yeah, we will.
Thank you. I'm sure you will. Make sure it's a nice red, okay?
Okay. Yeah.
So we'll have to get you a drink at some point in the future as well. But
Yeah.
That's well deserved, mate. Well done.
Yeah, delighted.
Yes, thank you. It's a relief.
So we'll see you on Thursday morning.
Friday morning.
Friday morning, yeah. Okie dokie.
Hanging around for a couple of hours, man, so we can have a bit of a chat over lunchtime.
Yeah, excellent. Yeah. Okay. All right, mate.
Sneaking a podcast.
Yeah.
Okay.
See you, Phil.
See you later, Phil.
Ciao. Thanks, guys.
Right. Well, that was good news, man.
It was great news, yeah. But meanwhile, before that rude interruption, where were we? We were still talking about the study. Okay.
Yeah, and the other thing we're doing, Martin, and it was actually an idea that you came up with, was we're going to do some focus groups and interviews with the cleaners to see about how they felt about being part of this study. But interestingly, we're also going to ask them about how they feel about receiving feedback and what do they like or not like. So we kind of got plenty of good studies out there that show the value of feedback.
Yeah.
Particularly for environmental services stuff. Built on Phil Carling's work years ago.
They didn't often describe how people felt about the feedback, or how they actually delivered it. They just said, we fed back.
That's right.
And I do wonder about that, because generally I find environmental service workers really want to do a good job. But if the feedback is punitive, then that has a negative effect. So it'd be fascinating to find out how they feel about how their work can impact on patients, and they probably want to see success. So maybe they're a bit more interested in the effect on, the better you clean, the number of infections are coming down, rather than just, you missed that bit over there and, you've only done 60% of the room. So that'd be quite fascinating if they would want it like almost a composite indicator of their practice, really. Things are drifting and maybe the cleaning has dropped a bit, and look, the infections are going up, and that might mean something a bit more to them, really.
That's right, and we're delivering the feedback in a structured way, but in a variety of different ways. So we're very deliberate with how the feedback is going to be provided, but at the same time, it allows us to try different types of feedback to get their qualitative feedback on what they liked. So some of it might be informal. We're doing that sort of informal chats. Some of it is a bit more structured through like an email. There's a little bit more of that sort of formal training side of it and providing the results in that sort of format. So it's in a variety of different ways that's being provided. So we'll get a bit of a sense on what do they find useful to help their practice. Yeah,
because that'd be an interesting one, because certainly in the UK, the cleaning staff of the environmental service workers, they wouldn't have a hospital email address generally, so they wouldn't be able to get feedback in that way anyway. So
sort of using a Teams group, like a Microsoft Teams group, to share that information. Because that's probably the better way that it's actually part of their existing process of strength. So we're not adding in something new, we're just doing something that's a bit of an add-on to existing process.
Okay.
One of the things today actually that happened, some of the doctors, a couple of doctors went up to one of our cleaners and said what a fantastic job they were doing. And it made their day.
I love that.
And it was just, and I was really warmed by that too. Because I thought,
how long did it take them to do that? 10 seconds. How much, what impact did that have on that cleaner's perception of how well they're doing their job, that a doctor recognises it?
That's right. And I've been trying to get this study up for funding for a few years and finally got it. And it was this kind of stuff I was hoping that would matter. The nurse unit managers are fantastic on the wards, and they're really engaging with the cleaning stuff. So what we're seeing really is a great safety culture being built, and cleaners being really feeling part of, hopefully, of the team and their own patient safety.
Are they employed by the organisation, or are they externally contracted?
They are employed by the organisation.
Yeah.
But look,
I have to say that doesn't necessarily mean you still can't build great relationships, and because at the end of the day, you're working together towards hopefully a common goal. And if you can instill that with your cleaning contracting company, then that can work as well. I don't subscribe to the view that it's not great to not, to only have employed cleaners. If that's the way your hospital system works, you have to find a way of making that work for you.
That's right. And look, we'll get some of this. I mean, that's anecdotal stuff I mentioned just then, but we'll get some of that more structured feedback about how the PSAs, the cleaners, felt about this study when we actually asked them in proper research methodology through a focus group.
You have to remember to go back and ask that cleaner and get her in the focus.
I know, we don't want to lose that one. That's a gem of a quote for the future. But the other thing I forgot to mention as well, for the actual intervention itself, it is a disinfectant 2-in-1 product that we're using.
Okay.
And sporicidal product for cleaning commodes. So that's the mainstay. What we're also going to look at is if there's any degradation of equipment through the use of this process. We can only do that quite visually, but we're keeping a track on that. We can't do that in a true laboratory microscopic sense, but we're keeping an eye on the quality of the equipment that is being now regularly cleaned, but possibly wasn't.
That's a different thing, really, because a lot of equipment was maybe not designed to be cleaned as often as we would like it to be cleaned, and maybe the manufacturer wasn't assuming that his vital signs equipment was actually going to be wiped maybe 10, 15, 20, 30 times a day when he designed it. So that also can have an impact. Yeah, you're right.
The other thing with tailored for ICU is, in talking to the staff there, they said were really concerned about a couple of areas where they thought transmission might be happening through the environment. And there's sort of little pod areas that staff would gather in outside of a patient area, where there will be a lot of same use of computers in a desk sort of area. So we're including that as well as part of our environmental swabbing and cleaning to focus on that, because that was the source that locally they thought might be an issue. It's perceived risk. So we thought, well, I might as well include that.
Oh, no, definitely include it. I mean, I have read papers showing in critical care areas, environmental contamination with patient-specific organisms actually can be quite widespread, because hand hygiene isn't always 100%, and people do move around, and equipment that is contaminated and not clean moves around as well. So it's often a lot more extensive than just immediately around the bedside. So, and also, why not? If they want you to look at it, why not? Because it helps them get on side, doesn't it? Really?
That's right. Yeah. So thanks for the chat about this.
No, I'm really looking forward to seeing the results of it, and in the not too distant future as well. This is only results this time next year, hopefully. So
that's right.
I look forward to seeing you presenting them.
Yeah, looking forward to it too. Thanks, Barton.
Cheers, Brett.
Talk to you soon.